everyone. Welcome back.
I'll take the honor to invite Dr. Shailesh Puntambekar. Sir is a laparoscopic cancer surgeon and robotic cancer surgeon, medical director, Galaxy Care Multi-Speciality Hospital. Considered as an expert in pelvic anatomy, conducted India's first successful laparoscopic assisted uterine transplant. Sir is here.
So it's indeed a privilege to invite Dr. Shailesh Puntambekar at this dais. And he's going to speak on the changing concepts in pelvic anatomy. And I must say that he has been my mentor in laparoscopic surgery. And we have been together at the evolution, and he has gone far ahead now, doing a wonderful work in not only uterine transplant. Recently we had our final MS OBGYN exams, in which we had this question, and everybody mentioned Dr. Puntambekar's name in the paper, that the first uterine transplant in India was done by Dr. Shailesh Puntambekar. So we are really eager to listen from you, sir.
Thank you. Good morning, everybody. Thank you, Dr. Girija, for such kind introduction. Thank you, World Laparoscopy Institute, Dr. Mishra, and my very close friend, Dr. Rajesh Shah, who took the pains to get me here under a lot of circumstances. So in the next 15 minutes, I'm going to talk about parametrium and the anatomy. Now, the biggest question all of you ask is how to do good laparoscopic surgery, and for that, irrespective of what kind of surgery you do, whether you do robotic, single port, whether you do laparoscopic surgery, anatomy, and nothing else but anatomy is important. We all learn the anatomy in this manner, that is by cutting open the cadavers, but now we are learning the anatomy to laparoscopy with 40 times magnification and understanding this better. Has anything changed in anatomy? No, nothing has changed in anatomy. Our perception of anatomy has changed, and anatomy is nothing but the network of fascias and planes, and we as the mortals have to find these planes. So it's all about anatomy, and nothing else but anatomy. So anatomy remains constant, but our perception of anatomy has changed. We are going to talk about these four things. The most important thing is a better knowledge of anatomy, not as an anatomist, but as an anatomical surgeon, is more important for you to understand. More so when you are doing laparoscopy, because what lies where, what comes next, and anticipation of the structure should be based on anatomical knowledge, and this is what we have coined the term, which is worldwide used now, is predictive anatomy. Predict the structures before they come. So as we put in the laparoscope, you can see the two median umbilical ligament. What do you infer from this? The bladder lies between the two median umbilical ligament. And look at the sacrum. The first structure that you see is the ureter. Sacral promontory remains the peak. Frank Nater and Gray's anatomy had classified abdomen and pelvic organs as separate. So pelvis starts at the level of the sacral promontory. It is the highest peak of the mountain from where none of the pelvic pathologies, like you take endometriosis, large fibroid, any rectal cancers, they don't go up to the sacral promontory. So if you understand this, whenever in difficulty, start your dissection at the level of the sacral promontory. What happens at the level of the sacral promontory? You have the bifurcation of the common iliac, you have the ureter crossing from the lateral to the medial side, and you have the superior hypogastric plexus. So this is how it is. This is the bifurcation of the common iliac artery, and of course the presence of the ureter, which continues to remain as the most medial structure. Let's now decide what are the fascias of the pelvis, because it is all about the fascias. We heard a previous talk about adhesions, and I'll tell you why the fascias are so important. There are four fascias: the cervico-vesical fascia, the endopelvic fascia, of course then the denon-villus fascia, and the Walder's fascia. So this is the endopelvic fascia, which covers the levator ani muscles. All of you have to understand this covers the levator ani and the endopelvic fascia. This is used for birch repair and multiples of other surgeries like the endometriosis as well as for rectal cancers, which is very, very important. The next important thing is that the fascias and the relation of the veins. Take any fascias in the body, right from the top to bottom, veins lie underneath the fascia. So if you remain anterior to the fascias, then you will never ever encounter bleeding. That is the principle of dissection. The second important dissection is that you have to understand that this is the denon-villus fascia. Now denon-villus fascia lies between the rectum and the posterior vaginal wall, and when you dissect, you don't have to use any energy source. You can just use scissors, because it's all about the anatomical dissection. You can see this, and this is what has become world famous. Fat belongs to the rectum is the dictum. Remain above the fat, just remain above the fat, and you will see the two layers of non-villous fascia which can be clearly seen. Even non-villous who described this didn't understand that the veins of the rectum lie between the fascias and the rectum. Remember good old days as gynecologists, you put your fingers inside, it bled because you went between the fascias and the posterior vaginal wall. So fat belongs to the rectum is the dictum. Similarly, the cervico-vesical fascia is the fascia which covers the anterior wall of the vagina. Fat belongs to the bladder, so you remain below the fat, and the veins of the vagina lie between the fascias and the anterior vaginal wall, which is very, very important to understand. And this you can see, fat belongs to the bladder, remain below the fat, and you can dissect this completely. So this is the cervico-vesical fascia. The veins lie below this. In good old days when you pushed the bladder, it bled because you went between the fascia and the anterior vaginal wall. This is what you can see. This is a robotic case. You can see that this is the cervico-vesical fascia, and you will see the veins going below the fascia. A lot of times people ask me, how do you control these veins? Do not try to go after the veins, just coagulate the fascia. The veins just come underneath. So this is the applied anatomy that you have to use when you want to do this. So this is the vein. Don't go after the vein, just coagulate the fascia, and that's the most important thing you can do. So again, the way, if you don't want to use, this is a sharp dissection. Fat belongs to the bladder, just go below the fat and push, go below the fat and push, and this is how you can see, you can clearly do this dissection very, very clearly. These are the rules of the game that have to be followed. Follow the anatomy, the visual anatomy, and this is very, very important to understand. Again, as Dr. Girija was saying in the previous talk, whenever there is a adhesion, don't go from the center side, go at least from the lateral side. The anterior bladder, the bladder lies anterior to the uterine artery. I have put a clip there. Never go below the uterine artery. Remain anterior to the cervico-vesical fascia. Follow the rules, follow the anatomy. Anatomy never changes. Just follow the rules, and you will see that you don't have any bleeding about this. And this is the most important thing. I'm not going to show you all these videos because there are, and then of course the last part, which is about this holy plane of Bill Heald. Bill Heald was from Nottinghamshire. He changed the concepts of rectal cancer into TME. This is the Walder's fascia. Again, you see veins lie below the fascia. That is the posterior fascia, and this is the Walder's fascia, which you have to understand. The Walder's fascia is the one which is there, and this is the area which you can do very, very good dissection over here. This is the dissection that you do when you do the rectal dissection. Fat belongs to the rectum, so go below the fat when you are doing the posterior dissection, and this is the area that you would like to go ahead and take out the entire fat. So this is the posterior dissection. Understand the entire fascias and the vein relationship, which is very, very critical to understand that this is the area in which you can go. So posterior to the rectum, when you want to go into the area that you are going to go into the Walder's fascia, this is the fascia you see now. This is the fascia, Walder's fascia. Just lift up the rectum. This is the TME plane, nowadays used by a lot of gynecologists also for doing the endometriosis, and you can see the presacral veins lying below the fascia. So this is very, very important to understand. Fat belongs to the rectum. What about the pelvic ligaments? The pelvic ligaments have been divided by the mortal surgeons as the uterosacral, the Becken rods, but they all come as a single fan-shaped structure. The uterosacral is the nothing but the fibromuscular thing. Then the Becken rods is a fibroareolar, and of course the anterior parametrium. And all these spaces are only seen when you cut the peritoneum. What is the most important thing all of you have to understand? Fascias lack fibroblasts. So if you do the dissection between the fascias, there will be never an adhesion. Because if you go through Gray's Anatomy, Frank Nater's features anatomy. Fascias lack fibroblasts. So no fibrosis if you go into interfacial plane. Only when there is a bleeding, blood causes these adhesions, and therefore in laparoscopic surgery the adhesions are less. What about the entire thing? Fascias are the toughest structure which prevent the cancer spread. So it is only through the lateral part where the cervico-vesical fascia splits into two to allow the ureter that the cancer spreads. You can go through this, the paper which is on YouTube. There is a video on this. This is a facial anatomy and its relevance. So significance of the fascias. The fascias are always in two layers. The veins lie below the fascia, and always interfacial lane will prevent any kind of adhesion. What about the spaces? There are 4 spaces that we would like to know. The pararectal space, which is probably the most important space if you want to do any kind of pelvic surgery. What is a pararectal space? It is not the space, because Gray says space is something which is lined by the peritoneal thing. These are surgical spaces. These are the spaces which are potential spaces. You need to find these spaces. The pararectal space is divided by the ureter into 2. The lateral pararectal space called as the Latsgo, the medial pararectal space called as the Okabayashi space, and the lateral pararectal space is the most important space. You can see this. This is the lateral pararectal space, the only structure that crosses the lateral pararectal space transversely is the uterine, and this is the most important thing which is important. And this is the way you can dissect. You can see the lateral pararectal space, the only space which crosses, the only artery which crosses this is the uterine artery. Medial pararectal space as the hypogastric nerve, also called as the Okabayashi space. So this is the pararectal space. This is what we published way back in 2009. You can open the pararectal space in 2 ways. Lateral to the infundibulopelvic ligament called as the oncological way, and medial to this is called as the endometriotic way back in 2010, and this is a recent paper which I will show you. So how do you open this space? You cut the peritoneum medial to the infundibulopelvic ligament, and when you cut the peritoneum medial to the infundibulopelvic ligament, the first structure that you will see is the ureter. That is the ureter. Now you can go and cut the peritoneum medial to the ureter to enter into the pouch of Douglas. Now you go underneath the infundibulopelvic ligament. The first structure that you see is the external iliac artery. Cut the posterior leaf of the broad ligament. Once you cut the posterior leaf of the broad, look at the way in which we do. Keep the 2 hands parallel and lateral to the ureter, and you will see, and push parallel, lateral to the ureter and push. The first structure that you see is going to be the uterine artery. This is the internal iliac space, and that is going to be the uterine artery, which you can easily see crossing it. The only structure that crosses water under the bridge, that is the ureter. And now if you remain parallel to the uterine artery, so that's the uterine artery. Now you remain parallel to the uterine artery and push. You can see the superior vesical vein, and you can see the paravesical spaces. So the key mantra is parallel to the tubular structure and push, and this is the pararectal space which is on the lateral side. Go up to the levator ani, and that is the paravesical space. These are the 2 immediate branches of the internal iliac artery, which is important. So you have to understand the pararectal space, and of course the medial approach is the one where you can go from the medial side, and this is the lateral approach which you can see on this side. So you see that on this side we are going lateral to the infundibulopelvic ligament, remaining parallel and lateral. Look at the way in which you can go from the lateral side, parallel and lateral to the ureter, just with a suction catheter, parallel and lateral to the ureter. The only structure which will prevent you from going down is the uterine artery. Simple concept, simple mode of dissection, the best way to tackle the pararectal space, and this is very, very important to understand and do this. So this is the pararectal and the paravesical space. This is the Okabayashi space, which you can see on the other side, which is medial to the ureter, and that is on the lateral side. So if you remain parallel and medial to the ureter, then you will see the hypogastric nerve. This is the hypogastric nerve, which is very critical in rectal cancers, in all the gynecological cancers, and this is the pararectal space, which is the medial space called as the Okabayashi space. So understand the modes of dissection, and then of course the rectovaginal space that I have already shown you. Fat belongs belongs to the rectum is the dictum. If you go, you can see at the tick, if you go through the fat, it's a bad plane. So attention during the dissection, the main rule is, this is again now completely validated by the recent paper in 2023 by Denis Guillot from France, that Dr. Puntambekar et al. Said fat belongs to the rectum. It is in apostrophe because the editor felt that this is a colloquial English and therefore they put it in apostrophe. So fat belongs to the rectum is the dictum, and this is what you have to follow. And this is the rectovaginal space. You can see, pull the rectum, go into the space, and then you can see when you do the rectal dissections, when you do the hysterectomy, remember the dictum, fat belongs to the rectum. Worldwide now it is used as this dictum, and this is very, very important for you to understand. So this is the dictum. I'm not going to show you again the same spaces. So then, of course, you have these spaces, and then I'm not the pararectal and the paravesical spaces that we have already seen, and of course the prevesical space. Just can I take 2 minutes more, sir? Because I thought it was 15 minutes. I'm sorry. So this is the fat. If you go into the prevesical space, again fat belongs to the bladder. So when you enter the cave of Retzius, remember to go between the two median umbilical ligament, because the bladder always lies between the two umbilical ligament, and then you can see fat belongs to the bladder. Remain above the fat because you have to go above, and you can go into the prevesical space. Everything has a visual clue. Remember the visual clue. This is important. You cannot palpate, but you can see better with laparoscopy and do it better. So this is the prevesical space. I will not go through the Yabuki space. This is the last space through which the nerve enters into the bladder, and this is the space where you have to preserve the hypogastric nerve when you do nerve sparing surgery. This is the Yabuki space, which is very, very important. And this is how the parametrium looks in the body. The lateral parametrium, which is the uterosacral, the posterior one. The lateral is the Mackenrod's, and the anterior parametrium, single fan-shaped structure which comes over there. I'm not going to show you this dissection because this is not very important. But all this is very, very critical when you do these steps, and this is how it can, and we describe this. You can go through this presentation of anatomical description of anterior parametrium. This was a probable answer for laparoscopy which is failing. Finally, in the last 1.5 minutes, I will take you through this fascinating vascular anatomy. You can see that the aorta, the IVC, and of course the common iliac and the external iliac artery do not have branches on the anterior side. So therefore there are no branches except the inferior mesenteric artery, and you can see there is no branch till the inferior epigastric artery. So what do you do? This is how it looks in the body. There are no branches, no tributaries on the external iliac vein, on the external iliac artery. How do you use this knowledge of anatomy? You use this knowledge of anatomy. This is how you can see this, and this is the common iliac artery which divides into the anterior division and the posterior division. We are more interested in the anterior division because that's what which gives rise to this. The only lateral branch of the internal iliac artery is the obturator artery, and this is the relation with the ureter. The artery goes above and the vein goes below. This is again against what has been written in the gray. So why do you want to know this? If there is a bleeding, you have to identify if it is an arterial bleeding, depress the ureter. If it is a venous bleeding, just lift up the ureter. This is importance of applied anatomy and understanding the knowledge of anatomy. So this is, there is no branch, no artery to this. Therefore, how do you do the node dissection? Just remain parallel and push, parallel and push, parallel and push, and this is how you can easily do. If you understand that if there were vessels, tributaries, it wouldn't have been possible. This is how understanding the anatomy and doing this. Again, this is to show you that the uterine artery goes above and the vein goes below the ureter, and these are the multiple branches. This is all the pictures to show you this. And the corona mortis, for general surgeons who are sitting here, it is nothing but the circumflex iliac vein going and meeting the obturator vein over there. So this is the double corona mortis. The ureter carries its own mesentery. You should not worry about the ureter. Ureter is like the hamburger, artery above and the vein below, and therefore you have to follow this. I'll not take you through this neural anatomy because of the lack of time, and these are all the nerves so which are seen. So significance I'm not going to tell you, but you have to understand that better understanding. This is the picture, this is the publication in the highest journal FIGO. You can go through these changing paradigms in anatomy and understanding the pelvic anatomy, and there are 90 citations for what we have done brain anatomy. We made this concept superb, duplicable, replicable by every surgeon. So all these are here, and you can see this is the latest publication of vascular spaces, where we have been quoted at least 12 times saying that all these are the concepts coming from India. So this is how you can do every surgery very easily. Take home message: uterine pathologies do not reach up to the sacral promontory, always remain parallel to the tubular structures, veins lie below the fascias, remaining medial to the hypogastric artery will damage any to the external iliac, ureter carries its own mesentery. But the last word is very, very critical and important. Having traveled in 50 countries and operating in 50 countries, I have yet to see an uterine artery arising from external iliac. What is the meaning? Pelvic anatomy is constant. There is no excuse, ladies and gentlemen, for any one of you to say that there is a distorted anatomy. Anatomy is never distorted. It is constant. It is your thoughts which are distorted when you are doing this. Get the anatomy right, get the surgery right, and one day you will realize that you are already doing what you thought was impossible in your hands. So anatomy remains constant. What has changed is our perception. Thank you again, Dr. Mishra. Thank you everybody, and thank you the chairperson for giving me extra time. Thank you very much.
Thank you, sir. Can I request the chairpersons to felicitate our speakers of this session? We'll be presenting them with a memento. I request all the speakers of this session to come on the stage. Dr. Mahin Nivad.
I think as always, Dr. Shailesh has given us a newer vision. And when we saw him doing open surgeries long time back, after the advent of the CO2 insufflation, the way the surgical anatomy was demonstrated by him has been extremely amazing and excellent. And we believe in Pune that the God was sitting next to him when he made the human body, and he was probably directing him to make it. So I think we can have a round of applause for Dr. Shailesh Puntambekar for such a wonderful rendition of this talk here.
Thank you for your kind words, ma'am. Dr. Mahin, Dr. Tharun, Dr. Marinda, Dr. Shailesh, I request you to be on the stage. Yes. Ma'am, the memento is on the... Due to time constraints, we are not going to be having the tea break. We'll continue with the next session while we have a tea, coffee, breakfast served outside in the lobby for our guests. Please feel free to grab a bite. Thank you, sir. Thank you, speakers, and thank you, chairpersons. For the next session,